Josephine Wiles, and today I'm going to be discussing my research proposal, which is titled The Impact of Individualized Nutrition Intervention in the Post-Transplant Recovery Outcomes. I am a dietetic intern and MPH student in the College of Public Health, and this is my presentation. A quick outline for today's presentation is going to include an introduction, a background and summary of the literature review, significance of this proposed study, the innovation, specific aims of this study, my research strategy, a timeline, clinical and public health implications, and references. So, Tampa General Hospital, which is the proposed location, has a transplant center which performs approximately 50 lung transplants per year. Lung transplant candidates and recipients are at high risk for nutrition-related complications. Some of these complications may worsen one-year transplant outcomes. Transplant recipients are evaluated by a registered dietitian nutritionist prior to transplant to assess for nutritional barriers to transplantation. However, there is no protocol for nutrition intervention or care in the postoperative phase at TGH, apart from a brief diet education from the RDN prior to discharge from the inpatient stay. Visits with the outpatient transplant dietitian are typically scheduled on an as-needed basis by patients or transplant coordinators, and the visits are currently not utilized as they could be. Additionally, it is often the transplant RDN's job to identify patients at risk. However, the current practice at the TGH Transplant Center does not have a protocol in place to screen all recent lung transplant recipients for nutrition risk. Transplant recipients go through extensive post-transplant medical management and treatment at outpatient clinics, which provides an opportunity to utilize an interdisciplinary approach to screen for nutrition risk. The medical management of solid organ transplant increases risk for a number of nutrition-related complications, including weight gain, weight loss or malnutrition, diabetes, hypercholesterolemia, high blood pressure, and osteoporosis. Weight loss and malnutrition in the perioperative phase is associated with higher rates of infection in the acute recovery phase and worse one-year mortality outcomes. In contrast, weight gain is associated with high uses of corticosteroids in the transplant recipient. Addressing weight gain may require structured nutrition and lifestyle intervention with clinicians. There are very few established standards for the coordination of care before or after receiving lung transplant. Additionally, the management of complications in this population can be particularly challenging due to the heterogeneous group that makes up lung transplant recipients in terms of age, underlying disease, weight status, and the presence of comorbidities. A multidisciplinary team approach to treatment may be the best for improving treatment outcomes. Other members of the healthcare team are to assist in optimizing the nutrition status of transplant candidates through nutrition counseling, dietary modification, and lifestyle changes. RDNs are uniquely positioned to improve patient outcomes with nutrition therapy due to their comprehensive training, expertise, and commitment to evidence-based nutrition therapy. The transplant RDN further specializes in recognizing transplant patients at nutrition risk and optimizing their nutrition status. There is a limited number of studies assessing nutrition intervention in the post-transplant phase. However, it has been established that an optimized nutrition status is associated with improved outcomes and survival after transplantation. Due to the absence of clinical practice guidelines for the nutritional management of lung transplant recipients, clinicians on the multidisciplinary team may need to use clinical judgment to optimize the nutrition status of recipients. In the early postoperative phase, which is often characterized by a catabolic energy balance, this will require correcting or preventing deficiency, supporting the healing process, and strengthening the immune system. As the patient shifts into the chronic recovery phase, nutrition intervention should focus on managing common comorbidities such as NODAT, obesity, dyslipidemia, hypertension, and osteoporosis. Attempts have been made to establish clinical practice guidelines. However, a lack of evidence stands in the way of specific recommendations. Based on a summary of the current literature, recommendations have been made to employ dietary interventions over the long term, start intervention within 1 year of transplant, follow established dietary patterns such as the Mediterranean diet, and accompany diet intervention with nutrition counseling. Completing this project will help identify patients with transplant-related nutrition complications in need of specialized nutrition intervention from the transplant dietitian, and it will utilize a multidisciplinary approach to do so. The significance of this study includes the fact that the survival rate of lung transplant recipients is increasing, and with it, the number of post-transplant complications that require medical treatment and management continues to rise. Without intervention, recipients are at significant risk for developing nutrition-related complications. Exposure to immunosuppressant drugs such as corticosteroids and calcineurin inhibitors used in post-operative management increase risk for weight gain, hyperglycemia, and lipid abnormalities. Malnutrition is common in the perioperative stage of lung transplant, and it is a concern for positive transplant outcomes. In a retrospective cohort study, it was found that a 5-year period, patients with severe malnutrition had a higher mortality rate of 44.6% than those who weren't malnourished, with 38.9%. The leading cause of death was infection, and there was a higher rate of death from graft failure and pulmonary causes in patients who were classified as severely malnourished based on the Nutrition Risk Index. There is a limited number of studies assessing nutrition intervention in the post-transplant phase. However, it has been established that an optimized nutrition status is associated with improved outcomes and survival after transplantation. Due to the absence of established practice guidelines, clinicians on the multidisciplinary team are required to rely on clinical judgment to optimize the nutrition status of recipients. The early postoperative phase is a critical period for optimizing nutrition status. Based on a summary of the current literature, recommendations have been made to employ dietary interventions over the long term, start intervention within 1 year of transplant, follow established dietary patterns such as the Mediterranean diet, and accompany diet intervention with nutrition counseling. The proposed research is the next logical step for building our understanding of the role of nutrition intervention in post-operative care of the transplant recipient. In summary, given the high rate of nutrition-related complications and malnutrition in the perioperative transplant patients, the significance and clinical relevance of this project is substantial. This study addresses early postoperative nutrition intervention for transplant recipients and proposes to explore whether mandatory follow-up with the transplant RDN at 2 weeks, 4 weeks, and then every 8 weeks for the remainder of the first year post-op can optimize 1-year outcomes and minimize nutrition-related readmissions. The proposed study will consist of a single-center RCT design. It will provide crucial feasibility data to inform a larger-scale efficacy trial to test the impact of mandatory outpatient follow-up. The proposed study will aim to enhance the visibility and role of the RDN on the interdisciplinary team. The findings from this research would help to shape the protocol for nutrition follow-up post-transplant. The proposed study uses a novel approach, single-center RCT, to evaluate the impact of enhanced nutrition intervention beyond the current standards of practice. The novel approach of the inclusion of an RDN and provision of nutrition intervention will inform future guidelines about the role of the RDN on the transplant interdisciplinary team. Attempts have been made to establish clinical practice guidelines. However, a lack of evidence stands in the way of specific recommendations. The results of the proposed research would help to clarify the impact the RDN can have on nutrition complications and transplant outcomes. Aim 1 of this study is to create a set of proposed recommendations for quality improvement for postoperative nutrition intervention for lung transplant recipients. We will refine intervention materials and propose a set of recommendations for screening guidelines for increased utilization of RDN outpatient follow-up appointment visits. We will create interdisciplinary education to ensure the interdisciplinary team is adequately prepared to implement the changes. Aim number 2 is to evaluate the feasibility and preliminary efficacy of structured nutrition follow-up on post-lung transplant recovery and outcomes. We will enroll 50 lung transplant recipients over the course of a year who receive a lung transplant at TGH and randomly assign them to the current practice standards group or the structured follow-up group. Aim 2A is to test the feasibility and evaluate the implementation of structured follow-up. We expect that structured follow-up will be feasible and well received by the lung transplant interdisciplinary team and patients. Feasibility will be measured based on feedback against benchmark for completion, participant feedback, and interdisciplinary team feedback. Aim 2B is to assess the preliminary efficacy of structured follow-up for improving transplant outcomes. We will examine the difference between number of readmissions and mortality outcomes at 6 months and 12 months. Weight change and nutrition status as assessed by RDN will also be considered. The exploratory aim of the study is to explore whether recipient nutrition status differs between the CPS and SFU group at 1 year follow-up assessment. Nutrition status will be assessed by transplant RDN at 1 year post-transplant. Weight change will be calculated, and overall nutrition status based on nutrition-related laboratory values and intake will be determined by the transplant RDN. The long-term goal of this study is to identify and implement nutrition intervention in the post-lung transplant phase and increase the utilization of the RDN on the interdisciplinary team, which will hopefully improve 1 year outcomes from transplant and decrease the number of nutrition complicated readmissions. The research strategy for AIM 1 includes clinic observation and evaluation of current practice guidelines. The Transplant Institute has a book describing the protocol for the transplant procedure, which will be analyzed. Additionally, a policy and procedure page from the clinical nutrition department explaining the consults and referrals procedure for outpatient transplant nutrition will be analyzed. Then a series of key informant interviews will take place. The interviews will be voice recorded and then analyzed for thematic similarities or discrepancies. There will also be a detailed audit of the interview, duration, and methods used to analyze the results. Certain quotes or phrases may be highlighted to illustrate the stakeholders' viewpoints and solutions to the problem. We will then develop recommendations. We propose that a list of screening guidelines and recommendations for improving provision of nutrition intervention in the post-lung transplant clinic be created for use by the interdisciplinary team. These will be reviewed by an expert before finalization. Certified clinical transplant dietitians, a special certification available to transplant RDNs, will review and finalize recommendations based on the current evidence base surrounding nutrition intervention post-transplant. A 20-minute training will be provided to all members of the interdisciplinary team to explain these new recommendations. The research strategy for AIM 2, which is to evaluate the feasibility and preliminary efficacy of structured nutrition follow-up, will include the study design, which is the pilot RCT, which is comparing the structured follow-up to the current practice standards condition. Lung transplant recipients from TGH will be recruited on a rolling basis. Nutrition assessment and randomization will follow. The intervention includes participants in the structured follow-up group receiving an outpatient telehealth appointment with the transplant dietitian at 2 weeks, 4 weeks, and every 8 weeks thereafter for the first year following transplant, whereas those in the CPS group will only receive nutrition intervention by referral, which is the current practice. Primary and secondary outcomes include the number of readmissions and 1 year nutrition status outcome. The equipment required will be technology for participation in telehealth appointments. Data collection period will include data will be collected by the secondary investigator at 6 months and 1 year post-op. Those in the intervention group will also have data recorded after each follow-up visit. Our hypothesis is that structured nutrition intervention in the recovery phase post-lung transplant will decrease the number of nutrition-related readmissions and improve 1 year survival outcomes. The proposed study will take place over 2 years. AIM 1 will be completed within the first 6 months during IRB approval for the experimental phase for AIM 2. AIM 2 will be completed by the end of the 2-year timeline. With survival rates of lung transplant recipients increasing, the number of post-transplant comorbidities that require medical treatment and management continues to rise. A team approach between the multidisciplinary team is essential to meet this demand and improve survival and quality of life outcomes among lung transplant recipients. This novel study will establish potential feasibility and preliminary efficacy of structured nutrition intervention in the lung transplant recipient population. If proven effective, these findings could improve the number of nutrition-related readmissions and nutrition-related outcomes from transplant. Additionally, if proven effective, these findings could lead to the establishment of new clinical practice guidelines within transplant clinics. Additionally, this project will identify and advance leadership opportunities for the registered dietitian nutritionist. Here are my references, which were used throughout the duration of this project, and the literature review and proposal. Thank you so much for your time. I appreciate it.